In JCI standards, ACC stands for Access to Care and Continuity of Care. And it really forms the foundation of patient-centered care. Access to care starts at the very first interaction, whether that's an emergency visit, outpatient booking, or referral. The organization must ensure that patients are seen according to the urgency of their condition. That's why proper triage systems are essential, both in emergency and outpatient settings. Continuity of care means that a patient's treatment must flow smoothly across departments. For example, if a patient is seen in the clinic and needs surgery, all information, including diagnosis, consent, and test results, must follow them without delay or duplication. This includes referrals, handovers, discharge planning, and post-discharge instructions. The following is a list of all standards for this function. JCI expects that all transitions, from doctor to nurse, department to department, or outpatient to inpatient, are documented, safe, and understood by the patient. It's not just about internal coordination. It's about the patient feeling secure and supported every step of the way. ACC consists of 7 standards which are explained briefly here. Let's get started. Starting with the first standard, ACC 1. Here, the standard demands that the care organization informs the community about its services and how to obtain care, and also screens patients to identify whether their healthcare needs match the care organization's mission and resources. JCI wants the organizations, whether hospitals or clinics, to improve access to their services. So the care organizations must communicate to the community about their services, their hours of operation, and how to obtain care. The next standard, ACC 2, is about the care organization designing and carrying out processes to provide continuity of patient care services within the care organization and coordination among healthcare practitioners. Ideally, the patient care process is dynamic and involves many healthcare practitioners, and it can involve multiple care settings and services. Depending on the scope of services provided by the care organization, patients may move through several departments and services while receiving care. For patient care to be seamless, leaders of the departments and services work together to design and implement processes for continuity and coordination of care among physicians, nurses, pharmacists, and other healthcare practitioners as appropriate. Now, moving to standard ACC.3, which, demands that there is a qualified individual identified as responsible for the patient's care. To maintain continuity of care, the care organization clearly identifies the individual with overall responsibility for the patient's care. This individual may be a physician in a hospital or clinic or medical center, a dentist in a dental center, or some other relevant and qualified practitioner. Like generally, we have a chief medical officer or medical director who is well known to the whole team and basically oversees the overall patient care throughout the organization. The next section of the ACC chapter involves chronic and complex disease management. Here, the standard ACC.4 binds the care organization to have a program to provide ongoing care and support to patients who have chronic diseases. When an organization provides ongoing care and treatment for patients with chronic conditions, the organization establishes a chronic disease management program. Chronic diseases are often defined as conditions that are long-term and are progressive over time, such as heart disease, chronic obstructive pulmonary disease, diabetes, kidney disease, asthma, mental illness, and others. These patients with chronic conditions have more frequent physician visits, emergency room treatments, and hospital admissions. Organizations that only provide specialty services, such as ophthalmology clinics, dental clinics, or diagnostic centers, may not manage patients' chronic diseases. However, these organizations must be aware of the potential effects of such diseases on the services they provide and the impact on patients. Additionally, the medical records of chronic patients or any of the patients seen over time who require complex care or have complex diagnoses contain profiles of the medical care and are made available to the healthcare practitioners providing care to those patients. Maintaining accurate and complete medical records of such patients is, really helpful to compare their progress over time with the provided treatments, as well as this medical file can be helpful for other specialities when in need. The next standard is ACC 5. Here, the JCI needs the care organization to develop and implement a process to refer patients to other healthcare practitioners, another level of care, other healthcare settings, or other organizations to meet their continuing care needs when these needs are not available within the organization or are out of scope. Such services may include social needs, nutritional needs, financial needs, psychological needs, or preventive health needs, or other support services. The patient's healthcare practitioner or another individual responsible for his or her care identifies the type of referral needed and the availability of such services. Furthermore, the care organization develops and implements a process to transfer patients to another organization to meet their continuing care needs. The JCI wants the patients to have the best care from the organizations they visit, and, on occasion, an organization cannot simply refer a patient to another source of care, but must actively transfer the patient to an outside organization. Such a transfer is based on the patient's status, lack of ability to self-transport, or other factors like emergency services which are not present at the facility. JCI further reiterates about the transfer between the healthcare professionals and between the healthcare facilities while observing how the transfer is done, who is responsible for this, who is responsible while transferring to other facilities, and what could be done if transfer is not possible. And, all these happenings must be documented and shared with the patient, family, or caregivers. The next standard might seem simple, but honestly, it's quite a complex one. Standard ACC 6 is all about patient education and follow-up. This means that instructions have to be given in a form and language that the patient can actually understand. For patients who aren't directly transferred to another healthcare practitioner or organization, it's really essential to provide clear instructions on where and how to receive continuing care. That's important to ensure the best possible outcomes for their care. These instructions should include the name and location of sites for continuing care, any return visits to the ambulatory care organization for follow-up, and guidance on when urgent care should be obtained. And if the patient isn't able to receive these instructions themselves, the family must be involved. Now moving to the last standard, ACC 7, where JCI wants organizations to establish a process for referring or transferring the patient and also to evaluate the need for transportation. The transportation needs of the patient are assessed when care is complete, when the patient is referred to another source of care, or when the patient is actually transferred to another care source. The organization's responsibility to provide or arrange for transportation or to contact the patient's family or friends for transportation really depends on the patient's condition and status. And here's another important aspect. Local laws and regulations must always be observed when offering transportation services to patients in these situations. So let's now look at a few common, frequently asked questions related to ACC standards. Question: how do you ensure patients receive care based on urgency? Well, we use triage systems in emergency and clinic settings to prioritize patients by clinical need. Question: what is considered a breakdown in continuity of care? Examples include missing handover documentation, unclear discharge instructions, or delays in arranging referrals or follow-up appointments. So, who is responsible for ensuring continuity of care? Well, all healthcare providers involved, including doctors, nurses, pharmacists, and administrative staff, must really work together to make sure care flows without any gaps. Is patient education part of continuity? Absolutely. Explaining the care plan, next steps, medication use, and when to return is all part of safe and continuous care. Access and continuity aren't just checkboxes. They are actually a core part of patient safety and satisfaction. When done right, they lead to better outcomes and, honestly, fewer errors. For more simplified JCI and healthcare quality videos, subscribe now to the Quality Pharmacist.